on with the discussion of HIV disease as it presents after the autoimmune disorders. And when we think of acquired immune deficiency syndrome, or AIDS, the cause of HIV infection is a virus. HIV is a parasite that is looking for a way into the cell, take it over, and then force the cell into making copies of the virus. The cell cycle continues and repeats over and over as long as there's a new host cell to infect. So AIDS is the most common immune deficiency disease in the world, and it has devastating effects as there is no cure. With the HIV process, the viral particle must have a host cell to get inside, and once the HIV virus has obtained entrance or entered onto the host cell, once it's inside the cell, it causes reversal of the cell's DNA with its own reverse transcriptase and integrase. It does this first by entering the host bloodstream and then hijacking, quote unquote, certain cells, especially the CD4 T cells, helper inducer cells. And remember what these cells do, the helper inducer cells, they call for help, they direct immune system defenses and regulates immunity. Remember, when we're talking about a virus-host interactions are needed after infection for the disease to develop. The viral particle, the HIV viral particle, features include an outer envelope with a special docking protein that does help its way to find those host cells. So you can see in this picture that the HIV particle, as well as the CD4 T cell, has that capability to attach onto each other. In this picture, you'll see the life cycle of HIV, and on the bottom part where you can see my arrow, those are how the medications associated with HIV have their effect. So once the HIV virus has entered the cell, the HIV must get its genetic material into the host's DNA. HIV is a retrovirus, which is able to insert its ribonucleic acid, or RNA, into the cell's DNA. The reverse transcriptase enzyme converts the HIV's RNA into the cell's DNA and will allow for mitosis to occur. And then additional HIV particles are made with the infected CD4 T cell using that host cell. The effects of HIV infection, once these CD4 T cells become infected, they become really kind of an HIV factory and can make up to 10 billion different new and viral particles every day. This new or infected genetic instructions then tell how the CD4 and T cells work. Gradually, the CD4 T cell counts will fall, and then the viral load, or the number of viruses, will increase. So early in the disease, the immune system can kind of keep up, but gradually over time then those CD4 T cell counts are going to fall. As that occurs, the immune system weakens, so we see an increased risk of death and in those patients that don't receive any treatment. A healthy adult usually has about 800 to 1,000 CD4 T cells. And again, this number will decrease with HIV disease. Some people develop acute infection within 4 weeks of HIV exposure. And those acute things are going to be fever, night sweats, chills, headache, muscle aches. So really kind of similar to a viral infection. And then over time, the person will feel well again. But as they're still feeling well, that HIV war is still kind of going on inside of them, and their body is continually under attack. As more CD4 T cells are infected or become unuseful, the patient will experience lymphocytopenia or increased production of incomplete and non-functional antibodies. They'll have abnormal functioning macrophages, which will put them at higher risk for bacterial infections, as well as fungal, viral, and opportunistic infections. A diagnosis of AIDS requires the patient to be HIV positive and have a CD4 T cell count less than 200, along with HIV accompanying infections. So on the next slide, you will see the classifications of HIV as categorized by the Center for Disease Control. So stage 1 is a CD4 count greater than 500. Stage 2 is 200 to 499. And in stage 1 and 2, the patient will have no AIDS-defining illnesses. Stage 3 then is going to be less than a CD4 T cell count less than 200 with HIV defining illnesses. So things like tuberculosis, repeat pneumonia, Kaposi sarcoma, candidiasis. And then stage 4 is any person that has an HIV infection, but we don't have any information regarding their CD4 count. So really when we're talking about HIV, we have to take into consideration the patient's CD4 T cell count as well as the viral load. So when we think about HIV progression, it can really take months to years, so it can kind of sit dormant in a patient's body who is taking antiretroviral medications and who is also decreasing their exposure to HIV. So personal life factors can affect timing of progression. So how many times has the patient been re-exposed? What other sexually transmitted diseases have the patient had? Nutritional status is always important because when we think about nutrition and we think about being immunocompetent, they sort of have to be hand in hand. And so we also want to consider the patient's stress levels. The way HIV is transmitted, they're listed out up here, can be sexually, parentally, or perinatally. And with sexual contact, it's male, an infected male to a female, and it can either be vaginal or anal intercourse. The thing that makes the female more susceptible is because of the amount of mucous membranes that the semen would come in contact with. Parentally are going to be needles or contaminated blood products. And since we have seen great strides in the decreased transmission from blood products, we don't see many of those nowadays, but there is still a 0.02% chance that your book talks about in reference from the CDC. So there is still a small, very minute risk, but it is still a risk. And perinatally is from the placenta, maternal blood and body fluids, breast milk, and it's from mom to the baby. HIV is not transmitted casually by sharing household utensils, towels, things such as that, mosquitoes or insects. The thing to remember is there is no available cure for HIV, and so we have to consider primary prevention. So with sexual transmitted, the CDC talks about the ABCs of safer sex. So with abstinence and a mutually monogamous sex partner, with each of them being non-infected, are really the only absolute safe methods of prevention. So that's why it talks about abstinence and being faithful. Condom use, we want to promote the use of latex or polyurethane condoms and latex gloves if they are doing hands to genitals. And for women, it's the encouragement of not only the condoms, but also dental dams if there's going to be oral to vaginal or oral to penile or oral to anal contact. The viral load, or the amount of virus present in the blood and body fluid, will increase the amount of viremia, which will also increase the risk of transmission. So encouraging patients to follow those safe rules. For parental transmission, proper cleaning of quote-unquote works. This is in reference to injection drug users, and we did talk about in class about proper ways to clean needles and syringes. Very small, availability of needle exchange programs where the injection drug user can exchange needles, but there are some of those programs coming out that way. When we provide education, it's really about maintaining their safety and prevention of spreading. With perinatal transmission, that's across the placenta or the fetus being exposed during the delivery and then through breast milk. But if moms are receiving heart therapy or the antiretroviral therapy, the transmission rate has gone down to about 8%. So early detection, early intervention is going to be better outcomes. In the hospital setting, really, needle sticks are the main means of occupational related infection of HIV. So it's, utilizing your standard precautions for best prevention. It's not recapping your needles, so using needleless systems, using the needles that have the caps already that you can pop up and use. So those will be important things to think about when you are on your endeavor of your nursing career. With your collaborative management, the assessment, we'd like to monitor these people regularly for changes in their immune functions so we know the progression of the disease. When you think about the history, consider age, gender, occupation, residence, any current illnesses, past illnesses, sexual practices, sexually transmitted infections, TB, hepatitis. The physical assessment and clinical manifestations, patients with HIV end up having profound immunosuppression, and once their CD4 T cells drop less than 200, that's where we're going to see HIV progressing into AIDS. So think about recurrent infection, possible malignancies. With the endocrine complications, there's a higher risk of cardiovascular problems, diabetes. We see weight loss due to wasting syndrome. We also see adrenal dysfunction. Psychosocial assessment, remember to set your biases aside when you're caring for these patients, because oftentimes we may see guilt, fear, anxiety, loss of relationships, so we will definitely have some work to do with them. Other clinical manifestations are listed out on this slide. With the age dementia complex, thinking neuropathies up to change in cognition. With their skin changes, they typically have dry, itchy kind of rashes, eczema type skins. So making sure we use proper cleansing and lotion, keeping their nails trimmed short so they don't break their skin integrity. The laboratory assessments are listed out on this slide, and we did discuss them in class. So when you want a specific lymphocyte count, we're looking at your CBC with differential. The CD4 T cell and CD8 T cell count, that's part of the immune profile. And when we're looking at the CD4 counts, what we're looking at is how well their immune system is still functioning. The two antibody tests utilized are the ELISA and the Western blot. And the antibody tests are used to measure the patient's response to the virus. It's not really looking at the number of viruses that are present. So the ELISA is inexpensive and fairly accurate. With the ELISA, they take the patient's serum and is mixed with HIV grown in an incubator, and if the patient has antibodies to HIV, they will bind to those HIV antigens, and then that can be detected. So they will have a detection of a positive result. But if the patient is tested too early after exposure, the antibodies may not be present, so the patient may end up having a false positive or a false negative with the ELISA. So that's where the Western blot comes into play, because it is more definitive and it actually will confirm the diagnosis if the ELISA is positive. There are some home tests that are utilized, but typically we have to have about a 3-month window after the exposure for most of these results to be reliable. Viral load testing specifically measures the number of HIV genetic material or other viral proteins that are present in the blood. We use viral load counts to monitor the effectiveness of therapy and see if we need to change anything as far as their medication regimen. There is a list of priority patient problems, so I would take a look at those. Preventing infections, so we have kind of mentioned the antiretroviral therapy. The heart means highly active antiretroviral therapy, and heart therapy is used to reduce viral load, improve CD4 T cell counts, and slow down disease progression. So when we think about the drug therapy, remember it not only inhibits the viral, it also inhibits viral load replication, but it doesn't kill the virus. So the viruses that are present will continue, but hopefully what happens is it will stop those viral particles from doubling. So when we think about our patients and medication therapy, we have to make sure that they will continue to be accurate about 90% of the time, taking their medications accurately so that they can maintain a constant blood level. Again, these are different things that we talked about in class as far as enhancing oxygenation. We talked about the use of O2, bronchodilators, steroid inhalers, steroid nebulizers. We also talked about the use of Roxanol inhaled to not only help with maybe some relaxation as well as oxygenation. Managing pain, so when we're managing pain, probably the things that we'll think about are really toward the end of the disease, then moving in toward systemic type medications, so using central nervous system depressants, maybe some of the barbiturates to help control anxiety as well as pain. Enhancing nutrition. Nutrition will be an important aspect of this, so consider INO, daily weights, utilization of good oral cares every couple of hours to prevent their mucous membranes from breaking down. And the one drug that I did mention was Megace that can help increase their appetites. For tissue integrity, they do have several bouts or complications of having diarrhea. So we'd like to make sure that if they are incontinent, that we are maintaining good skin integrity by the use of perineal cleansing, keeping those areas dry, changing wet linens, those such things. And then with the skin integrity medications, a lot of those antiretroviral drugs will help with the Kaposi sarcoma. And then again, just maintaining appropriate skin care for the patient. Minimize confusion, so offer reality reorientation. We might see some psychotropic drugs used to manage behavioral problems, safety measures in the home as well as in the hospital setting, and being honest and sensitive to support, find out what type of support systems they have. The following slide talks about self-esteem and things that we can do to help our patients gain some self-esteem, because again, that will probably be a huge issue because of the stigma that having HIV and AIDS can carry with a person. For community-based care, we need to assess for self-care ability, talk about resources that are available, making sure that we get the proper assistive devices in the homes. Maybe we need a certified nursing assistant, maybe it's a home health nurse, but definitely assessing what they can do on their own and what resources are available and what we can get for them. With priority for teaching, we want to make sure that we teach them how to prevent the transmission. So discussing preventative behaviors, discussing infection control and nutrition. And the study we did in class, so the answers for this one are A, C, and D.
When we are thinking about the instructions to give the UAP, we would instruct her to offer the patient rinses with kind of like a salt water rinse every couple of hours, using a soft toothbrush, remind the patient to drink plenty of fluids, and then also have the nursing unit assistant report any mouth pain because we may be able to administer analgesics or utilize viscous lidocaine to help decrease the pain. When we think about teaching mechanisms, we really want to talk about standard precautions, good hand washing, prevention of transmission, talk about the use of a 1 to 10 bleach solution for about 5 minutes to clean up any body fluids. If bed linens or clothes become soiled, we want to make sure they're washed in the hottest water available with 1 cup of bleach per load. And then obviously if they have sharps, disposing of those properly. And remember, when we are talking to our patients, it's always good to provide therapeutic communication and active listening. Allow the patient time to openly express their feelings about the disease. In class, we talked that this statement is false, and it's false because the HIV genotype test is used to determine whether any mutations exist in the strain of HIV that has infected the patient. All of these answers apply. And with this one, since we're talking about first symptoms, it's going to be the fever, night sweats, and muscle aches. So I need to finish up then with care of the patient with immune function excess, so hypersensitivities or allergies. And when we discussed these in class, we really talked about 4 different types. So when you think about rapid or type 1, actually, let me back that up. Let's talk a little bit about what hypersensitivities and allergies are. So when we think about hypersensitivities and allergies, it's that increase or excessive response to the presence of an antigen. So it's once you get exposed to something, then your body reacts by initiating the immune and inflammatory response. So when we think about the degree of reaction, it can really range quite variedly from either uncomfortable with like hay fever type symptoms or life-threatening where you think about anaphylaxis. And so when we talk about the hypersensitivities then, when we are thinking about rapid type 1 hypersensitivity, it's really the most common. And with type 1, it's excess immunity with acute inflammation. And it's caused by the increased production of IgE. And when the IgE responds to the allergen on the mast cell, it causes release of chemical mediators. So those chemical mediators are going to be your histamine, bradykinin, serotonin, those such things. And so when we think of type 1, there is a quick response to that. Way the allergens can be contracted, we can either inhale them, ingest them, inject them, or contract them. So your latex allergy would fall into this category. And when we think about anaphylaxis, anaphylaxis is really the systemic shutdown after an exposure to either a medication, to a bee sting, to peanuts. And really when we have anaphylaxis, we actually have circulatory collapse. So we have blood vessel dilatation, decreased cardiac output, and bronchoconstriction. So our patients oftentimes have a lot of difficulty breathing, and we'd like to treat them prior to this happening. The next few slides kind of talk about allergic rhinitis, and we talked about some triggers in class. So triggers being plant, pollens, dust, mold, dander, air pollution, any of those types things. And when we have an allergic reaction, what happens is that we have the receptors on the basophils and the mast cells kind of combining, and then we have degranulation and histamine release. So when we have that histamine release, that's where we get the itchy, watery eyes. And we talked about some of the medications that we would consider using, and so the decongestants, antihistamines, those type things. When we think about our patient's history, it's really important to consider when the exposure occurred, so we know how much time we've been dealing with. We also want to know what they've been exposed to. When you're looking at your physical assessment and clinical manifestations, we did sort of talk about those a little bit. So it could be as mild as hay fever to as severe as anaphylaxis, that also is accompanied by angioedema, facial swelling, and those such things. When we look at laboratory assessments, typically what we're going to see on our laboratory assessments are going to be that increased eosinophil count. We can also see allergy testing done. And you also might you might see patients having the RAS test done. And when we're looking at the RAS test, it's really kind of like challenging your patient almost. And RAS stands for radio allergosorbent test. And when we see patients having this RAS test done, it is greatly increased with allergies. And we can also see allergy testing or skin testing done, which can show us what specific allergens are the cause of the type 1 reaction. So there are a few different opportunities for our patients to have done when we are considering how to diagnose. As far as interventions, we need to consider avoiding the things that actually cause the allergy to begin. I briefly mentioned the drug therapies. So when we are considering drug therapies, we consider the use of decongestants, and decongestants are really systemic drugs, but we can also utilize nasal sprays. A lot of times those decongestants will contain ephedrine, and so we need to caution our patients that have high blood pressure and cardiac problems. With the antihistamines, Benadryl is pretty common. Claritin, Sertrazine or Zyrtex, fexofenadine, which is Allegra. We might see the utilization of corticosteroids because they decrease inflammation and excess immunity. Mast cell stabilizers can come in nasal sprays. So cromolyn sodium is one that helps prevent mast cell membranes from opening when that allergen binds to the IgE. So the mast cell stabilizers are really going to be good for patients that have allergic rhinitis, but they're not really useful in patients that are having acute episodes. The leukotriene agonists are also quite popular. And what those do is they prevent leukotriene synthesis. And so with that, you kind of have to go back to the chapter on inflammation if you're not familiar with those. We can also think about maybe some other complementary alternative therapies, herbal supplements. Those those types of things. And then we can have desensitization therapy, and those are also known as like allergy shots, where you are administered a very small amount of the allergen, and then you allow your body to react, and then you eventually you have these shots continued, usually weekly over a period of a long time, and then your immune response can decrease to those. So those do take a long period of time. Anaphylaxis then is the severe life-threatening type 1. And so when you think of someone experiencing anaphylaxis, medical management is really going to be the most important aspect of their care. Type 2 then, or cytotoxic reactions, and if you are not familiar with the anaphylaxis, please take some time to do some reading on that prior to taking the exam. With cytotoxic 2 reactions, the body makes special autoantibodies directed against self cells that have some form of foreign protein attached to them. So when you are thinking of type 2, that's a reaction of IgG with a host cell or with an antigen, and then that's absorbed by the host cell membrane. So a lot of the autoimmune disorders, such as Goodpasture's hemolytic transfusion reactions, so your blood transfusion reactions, hemolytic anemias, myasthenia gravis. And when we have those cytotoxic reactions, we again remember from cellular mediated immunity and antibody mediated immunity that we have the antibody antigen complexes that can build up, and then those complexes are what cause other areas of the bodies to be kind of clogged up. So those lead us into the type 3 immune complex reactions, and that's where we have excess antigens that cause immune complexes to form in the blood. A lot of times folks that have the immune complex type 3 reactions will end up having some type of kidney involvement, so it'll be very important to consider kidney function tests. We see these type of reactions with serum sickness, systemic lupus erythematosus, as well as rheumatoid arthritis. And the last thing that I will talk about today is delayed hypersensitivity reaction. And your delayed hypersensitivity reaction, those are reactions of sensitized T cells with an antigen and release of lymphokines, which activate macrophages, and that's what starts the inflammatory process. So we see these as being delayed reactions, so it takes a little bit of a longer period of time for us to start seeing inflammatory responses. So we see these a lot of time with poison ivy, graft rejection, and we can also see it with a positive TB test. Again, if you have questions over the content, please feel free to email me, call, or stop into the office, and I will be more than happy to help you with any questions you might have.